All right, let's talk about something that should be simple, but somehow confuses everyone. When is the gallbladder a real problem? We are going to talk about why half the consults you get for gallbladder problems aren't gallbladder problems at all. The typical consult goes like this. Patient has some vague abdominal pain, someone ordered a CT or ultrasound, and lo and behold, there are gallstones. Consult surgery. Or better yet, patient has no abdominal pain whatsoever, just some nausea and vomiting or whatever. Imaging shows gallstones. Call surgery. Or my personal favorite, elderly patient admitted after a fall. Imaging shows a distended gallbladder or gallstone, so on hospital day 33, call surgery. Despite the diversity of these consults, we surgeons keep it simple. For us, it all boils down to one thing. Will removing the gallbladder improve the patient? And like one of my professors used to say, it is very hard to improve an asymptomatic patient. So the real question is, does the patient have gallbladder-related pain, or as we'd like to call it professionally, biliary pain? Ask any medical student or surgery resident about what biliary pain is. They'll rattle off right upper quadrant pain, postprandial, associated with fatty food intake, nausea and vomiting. Maybe they'll throw in Murphy's sign for extra credit. Here's the problem. That's just textbook babble. It's an oversimplification, which means if someone came in with that exact presentation and you didn't think of the gallbladder, you're not good enough to become a doctor and would fail the exam. That's why we teach you that, the classic ideal presentation. Yes, you'd wish your patient would come and say, "Doctor, I ate a greasy pizza and now I have right upper quadrant pain along with nausea and vomiting." But that's not the common presentation of biliary pain. So let's talk about what biliary pain actually looks like. Keep in mind these 5 characteristics, which are also augmented by internationally accepted guidelines such as the Rome 4 criteria. Number 1, location. Most people think gallbladder pain lives in the right upper quadrant. It doesn't, or at least it doesn't start there. Biliary pain is typically epigastric, upper abdomen, midline or slightly to the right. It's visceral pain from a distended gallbladder, and visceral pain is notoriously vague and poorly localized. Think about appendicitis. Where does it start? Vague around the periumbilical area, and as the inflammation progresses to the parietal peritoneum, it becomes more well localized to the right lower quadrant. Gallbladder pain follows the same principle. It starts epigastrically. Patients often don't even call it pain. They call it discomfort, fullness, or bloating in the upper abdomen. It's after some level of inflammation sets in and biliary colic becomes cholecystitis that the pain gets more to the right side. Number 2, progression. Biliary pain builds slowly. This is very important. This pain builds slowly. It is not a pain that is most severe in the first few minutes. It may start suddenly, but the intensity crescendos gradually over minutes to hours. If your patient describes sudden severe pain that was maximal at onset, think about other things like a perforated viscus, a kidney stone, or aortic dissection, not biliary colic. Number 3, duration. This one is critical. Biliary pain lasts at least 30 minutes, usually longer, often hours. If the patient says, "I get these sharp pains that last a few seconds and then go away," that's not biliary colic. I don't care how many gallstones are on the ultrasound. The gallbladder doesn't work that way. It takes time for a stone to obstruct the cystic duct, for the gallbladder to distend, for the wall to stretch, and for the visceral afferents to start screaming. That process doesn't happen in seconds. Number 4, not related to bowel movements. Biliary pain is not commonly associated with bowel movements. If a patient reports pain with diarrhea or relief after a bowel movement, it suggests an intestinal issue like colitis, inflammatory bowel disease, IBS, or functional bowel disorder, not gallbladder. Now notice I said not commonly. It's because we don't want you to miss a gallbladder problem because once in a while it was followed by bowel movements. The Rome 4 criteria allow for up to 20% association with bowel movements. So occasionally, sure, there might be some overlap. Number 5, response to acid suppression. Biliary pain does not improve with antacids or PPIs. If your patient says, I've been taking omeprazole and it really helps, that's not biliary pain. That's dyspepsia. Reflux or peptic ulcer disease, that's something acid-related. The gallbladder doesn't care about your proton pump inhibitors because it is not making acid. Feel me? So in summary, the main characteristics of biliary type pain are that it is epigastric and not always the right upper quadrant, builds slowly, lasts for at least 30 minutes, and is not commonly associated with bowel movements, acid suppression, or postural movements. You really need to drill into the patient history and ask several leading questions until you clarify these details thoroughly. With all these, you can now establish if the patient has biliary pain, and this happens all in the history taking part, not even clinical examination. Now, after you have diagnosed biliary pain, the diagnostic paradigm goes like this. Biliary pain plus gallstones or sludge on imaging equals organic gallbladder disease. This includes biliary colic, acute cholecystitis, chronic cholecystitis, acute on chronic. You get the idea? This means gallbladder is the problem. You can help the patient by taking it out. So take it out. Biliary pain plus no gallstones or sludge on imaging equals functional gallbladder disorder, like biliary dyskinesia. This is where things get murkier. It's debatable whether you can consistently improve the patient's condition by removing the gallbladder. But here's the critical point. For all these, you must first establish the presence of biliary type pain. If you don't have biliary pain, you don't need to worry about the labs or imaging findings. Bottom line, no biliary pain equals do not remove the gallbladder. Exceptions include complications of gallstones like cholecystectomy and pancreatitis or cancer. Got it? If you remove the gallbladder on a patient who does not have biliary type pain and gallstones, you run the risk of your patient not improving after surgery while incurring the risks of surgery. Yes, occasionally the pain might go away after an unneeded surgery, but that's probably a placebo effect, or the general recovery from surgery masking symptoms, or just the natural fluctuation of whatever was actually causing the pain. You can't attribute it to the cholecystectomy if the gallbladder wasn't the problem in the first place. And you may have noticed that throughout this entire discussion, I haven't mentioned about HIDA scan once. That's intentional. Let me be crystal clear here. You don't need a HIDA scan to tell you if you need to remove the gallbladder, okay? We will talk about the misuse of these scans in another video. So the take-home message is this. Even in this modern day in 2026, when you have mind-boggling investigations that can scan every millimeter of your body and watch cells move in real time, surgical decision-making to remove the gallbladder still depends fully on history taking. 99% of the decision is made before you even touch the patient for a physical examination, let alone looking at the scans. And when in doubt, talk to the hospitalists. On any given day, they juggle 15 active problems across 15 patients, coordinate with a dozen consultants, and still find time to place a well-reasoned surgical consult. But we waltz in, spend 10 seconds poking the belly, dismiss the whole thing, and act like they've ruined our day. Hospitalists probably know more about the patient than we surgeons do. So good luck with your next gallbladder consult. And if you have any questions, feel free to write to me on any of these platforms.